All right, so welcome everyone to our first career chat. My name is Michaela McGuire. We also have Shai here. Shai, do you want to say hi so you can pop up into the recording?
Hey, I'm Shy. Nice to meet everybody. Nice to see everybody.
And we also have our special guest, Mr. Steve Wechsler.
We should have practiced that first, Michaela. Wechsler, like an X, like an X.
See, exactly. This is why we need to have it recorded so the next person doesn't make a mistake. But yeah, so we're super happy to have Steve here to share about his experience in the oncologic rehabilitation field and also share a little bit of experience about his PhD path. So welcome, Steve. Thanks for coming.
Thank you. Nice to be here.
So I'll let Shai start it off with a question, and then we'll kind of just ebb and flow as we go, see what you got to tell us.
Sure.
Hey, Steve.
Hey, Shai.
So thanks for being here. Also, a quick thank you to Rick White, Claire Lou, Tori Crook, and Ellen, I'm going to butcher her last name, Comhair, I think. They helped us put this together, and they really did a lot of the brunt work. We're sort of just the pilot, the study to do this, but they put in a lot of the work, most of the work. So I want to thank them. And I know some of them couldn't be here because they're in clinical, but they will catch up. That's why we are recording. So I guess, Steve, first we want to start off just with a little bit of a background. And so if you can just tell us, briefly your elevator speech, where you are, what you're doing, and just sort of a quick overview of that part.
Sure, it's sort of fun. We're starting at the end of the story.
All right.
So I am Steve Wechsler. I am currently located in Boston, Massachusetts, Somerville, Massachusetts, if we're being specific. And I'm in the pursuit of a PhD in rehabilitation sciences. So I have a feeling there will be questions about that. So I won't dive into that yet.
Yeah, definitely. And just for everyone to know, we're sort of going to ask some general questions, some questions about sort of Steve's life, just so you get to know him as a person, and then we will slowly transition into that aspect of his career. So to bring it back a little bit, just wanted to ask what your favorite setting was in PT school, and where you sort of thought you were gonna end up.
Practice setting, I assume we're talking about. I never, being a big Yankees fan, I sort of assumed that I was going to be like the physical therapist for the New York Yankees. That was the dream. And then when I realized maybe I had to set my sights a little bit more realistically, I never really saw myself as an outpatient orthopedic PT. I got through a couple of rotations in school. I went to Ithaca College. Shout out to the Ithaca College Bombers that are on the call. And I learned a lot from my outpatient rotations. I learned a lot of manual skills. I learned how to assess the body from an outpatient orthopedic standpoint. But it never really hooked me. I gravitated a little bit more towards my inpatient acute care rotations. I think I liked sort of the hustle and bustle of a hospital. I liked the medical acuity of the patients that I was seeing. I felt like there was more, it was more exciting. There was like more danger in my everyday life than people coming in saying, ow, my back hurts, ow, my knee hurts. So getting ready to depart from school and enter the real world, I had a feeling that I wanted to be in a hospital setting. Thinking that would be a good position for me also to learn a lot of different things fresh out of school, which I thought would be sort of a good stepping stone to what I might want to do next.
That's awesome. And so you said you want to kind of head towards acute care. So when was the first time that you heard about the oncology field, and what did you think about it when you first heard about it? Or did you just go straight towards something else prior to?
So in school at Ithaca, and this is no knock on Ithaca, because I think this is really common in a lot of programs. There was almost no programming or no curriculum built around oncology rehab. You know, we had some in our pathology class. We had a guest speaker who was actually a cancer survivor come and speak to us about his experience, which I remember that. But once I got out into an acute care setting, I ended up during one of my affiliations, I think it was actually just my second affiliation, on an oncology floor. So I was a bit exposed at that time, but I didn't fall for it. Not to say that I didn't like it, but I didn't find anything particularly memorable about it at that point, I guess. More it was just an acute care setting. And so I eventually graduated and ended up going into a neurologic rehabilitation center, inpatient rehab center, working with patients after stroke and brain injury and spinal cord injury. And so that was sort of the first step out of school. So pretty different end of the spectrum, I guess. Well, not end of the spectrum, but pretty different than oncology rehab from the get-go.
I'm sure you learned quickly that being in neuro is not far off from being in oncology rehab. There's a lot of crossover. And so how did that sort of transition from you became an NCS, correct? And then you transitioned. So how did that sort of look like from being heavily sort of neuro-based and then now becoming sort of working with the oncology population?
So I feel really fortunate to have landed in a neuro rehab right out of school. And I found myself working with these patients and with these families during really critical changes in that patient's life, sometimes really catastrophic changes, you know, depending on the severity of the injury. And I really loved that setting, being able to create a positive environment and you know, make therapy a really positive experience and work for positive change with these patients and their families. I liked sort of managing the whole case, thinking about it that way. And so I did sit for and earn my NCS, my neuroclinical specialist status. And actually, it wasn't so long after that I ended up looking for a new job, and that was sort of circumstantial. The hospital wanted me to rotate to an area that I wasn't so passionate about rotating to, and so I looked for something new. And there was a job opening at this internationally known cancer center, Memorial Sloan Kettering, in New York City. So I applied and I got the job, honestly not knowing that much about oncology rehab still. But something that really enticed me about the job was that they sort of assured me or presented to me this really comprehensive onboarding and orientation process. So I had faith that I would learn what I needed to learn by the time that I got there. And not to jump too far ahead if this was a separate question, but what I found in oncology rehab was really similar to what I fell in love with neuro rehab. These patients were coming even to an outpatient center, which is the setting that I worked in at Memorial Sloan Kettering, with a certain level of medical acuity because of their oncologic diagnosis or their medical history. These patients were not, they might come in and say, my back hurts or my knee hurts. But there was this extra layer of complexity to every case that I really enjoyed trying to dissect and sort of solve the puzzle of every patient. So it added a level of intrigue or an extra challenge, I think, to every patient that I really sort of fell in love with there.
I definitely think that the complexity ties both practices together. And I was wondering if you had specific things from your neuro background that you still use in treating people with a cancer diagnosis, or a specific patient instance you might be able to give or something like that.
Yeah. Part of what I think anybody who works in oncology rehab will tell you is that you are constantly pulling from every toolbox you've ever put together in the back of your mind. So you're pulling on neuro, you're pulling on ortho, geriatric because of the type of population that many cancer survivors are, pediatric because of the population that some cancer survivors are, and everything in between. So my neuro background and my neuro skills come into play often when I'm working with a patient with a history of cancer. A common side effect of cancer and its treatment that we see is chemotherapy-induced peripheral neuropathy. I could go on. I don't think this is the focus of this talk, but I could go on and on about the fact that cancer survivors are at increased risk of falls, up to 2 times the risk of falls than people who don't have cancer. So doing a lot of balance training, doing a lot of gait training. It's just one of the many facets of this population.
Yeah, and I think, having been working in the acute care setting, in the acute oncology setting, like you said, the amount of orthopedics I see, the amount of neuro I see, the amount of geriatrics I see. And I think when people think geriatrics, they sort of think, older populations. But one thing that, if you don't have experience in the cancer population, the amount of sarcopenia that occurs in cancer patients, that sort of geriatric population, that geriatric body type can occur much earlier than sort of 65 and older. And sort of the comorbidities that occur can happen much younger. And so I think that's important to consider, that even though geriatric, we may put them under an age group, the body type, the protein synthesis and things of that nature can occur much younger. And so I just think it's, like you said, there is such a carryover between all those other specialties and oncology. And I think that's what keeps things extremely interesting.
Yeah.
This is a pretty, I think this is a hard question to hone down, but if you could think of one thing in your career that sort of brought you to this place now, what do you think that is? What is the best thing you think that did in your career that brought you to this place?
This place meaning going for a PhD, or just this place, this time?
Open-ended.
Open-ended. All right, so open-ended. So I'll answer with a couple answers. So one answer, and I promise it's not just because we're in this talk sponsored by APTA Oncology Student and New Professional Subcommittee. But one of the best things I've ever done in my career was to get involved with the APTA, with APTA Oncology. At the time that I got involved, it was known as the oncology section of the APTA. So that was another thing. In school, my professors always did stress the importance of being a member of APTA, seeking involvement and seeking leadership roles. I actually, whenever I heard that, I sort of felt like it didn't apply to me for whatever reason. It just it never grabbed me. And then an opportunity sort of fell in my lap soon after I got into my position at Memorial Sloan Kettering. A supervisor sat me down, and she had a position within APTA Oncology. And she sat me down and asked me if I knew how to make tweets. And I interpreted what she meant. And I said, yes, I guess. And so she brought me on to help with the social media platforms of the oncology section. And it was just a foot in the door. And since then, it's been one door opening after another. And it's done wonders for my career in terms of the network of people that I'm in touch with, the opportunities that I've had to speak and to lecture and just to sort of be at a table with other great thought leaders within the field. So that has been one of the best decisions of my career. I will also say, and this has sort of been a recurring theme in my career, the best decisions that I have made have been to not be complacent and to continue to seek blank, to continue to seek a challenge in sitting for the NCS, or to continue to seek continuing education in an area that I was interested in. When I was frustrated at work, Not to say that when you're frustrated at work, you should get up and go find another job. But when I wasn't feeling fulfilled and wasn't feeling challenged by the work that I was doing, I pursued other options, and it has landed me in one position after another, including now where I'm going for this PhD, where I feel totally fulfilled. I feel challenged. I feel a little stressed, but this is this period in time, right? So I think not being complacent and continuing to sort of push the limits of myself and of the field, hopefully, I think that's been a theme of the best decisions that I've made.
I think that not being complacent is some of the best advice you could give, because I think it's kind of scary when you want to make a change or you feel like you need to make a change to actually make that change, and you're living proof that making the change works, or at least trying to make a change works. So that's always great advice. Wondered if you could speak a little more about your path to your PhD, what value you're gaining from pursuing it, and maybe also what goals you've set for yourself within your career in having a PhD.
Sure. So I'll go back to Ithaca again. I had a wonderful professor by the name of Barb Bellier, who offered me a position as a teaching assistant, a graduate teaching assistant, because she knew that I had a passion for teaching, and thought that was perhaps a long-term goal of mine, which it was. And I fell further for teaching at that time. And so I always knew that teaching and being a professor and being in front of a classroom was sort of the long-term goal. So I've sort of had this idea that maybe I would pursue a PhD as a means to that end. And so after working a couple of years, I guess I had worked 7 years clinically between my first and second job. I sort of felt like I was at a crossroads where I could continue on the path that I was on and maybe work my way into like management and sort of go that direction, which I've never really had a huge interest in. Or I could think about, again, making a big shift and pursuing this PhD. And so, well, needless to say, you guys know the end of the story. I made the shift. I'm now pursuing this PhD in rehabilitation sciences. And the program that I selected, which is at MGH, the Institute of Health Professions in Boston. Part of the reason I chose their program was because they put a big emphasis on preparing me and preparing any student in the program to enter academia, to become a professor. So that's sort of what drew me into the program, and sort of it's been interesting since being in the program since last September. So I'm now in my second year as a PhD student. I'm sort of falling for the research side of things. I came in thinking like, yeah, I want to be a professor who maybe does some research or maybe gets like my students to do the research for me. But the ability to take the questions that I always sort of had in my clinical world, why is that patient not getting better? Why is this type of patient that I see in the clinic not getting better the way I would expect them to? Or, we're treating this patient based on this idea, but why aren't we treating them based on this idea? Taking those questions and actually learning how to think about those questions in a way that I can develop a research question and a research protocol and think about how to implement a study to investigate that question. It's really cool. And so I'm sort of falling for that side of it. I still think, the teaching part is going to win me over because that's always been my dream. But the research side is really cool. That's what an understatement. The research side is cool. It is cool. I've reflected on sort of what I think I'm learning on the larger scale in this PhD program. And this also might sound egalitarian or something, but I feel like I'm learning how to think. In a lot of ways, this program, they've like brought us in and then they give us an assignment or they give us a question and they kind of push us out of the nest. And it's really sort of forcing us to think on our own, think on our feet, think in different ways than we've thought before. It's certainly in different ways than I thought in the clinic, about how to answer questions or how to ask questions. I think is an important part of it too. So it feels a little bit nebulous, because it is sort of dynamic, and it's been a great process. I'm excited about where I am now and still where I have to go.
Awesome. Well, I have some questions on that, but before we keep going, I sort of want to take a pause. We're about 20 minutes in. We didn't really have a time frame for how long this is going to go, but we were going to try to keep it under an hour. Was there anybody of the other 12 people in this chat who wanted to ask a question? You can always share it via chat, and Michaela and I can read it. You can just sort of hop in and ask. You can do the little raise your hand button, whatever you like. I'll give about 30 seconds, see if anyone's interested.
I have a quick question.
Sure.
So you mentioned that your patients that you worked with in oncology are recovering or after their chemo has finished. How does that work in oncology? Is that typically the moment where PT interventions are taking place, or can you work with the patient as they're actively going through a treatment?
What a fabulous question. Is it Haley? That's a great question, and I'll try and condense an answer. The answer is yes. No, so what the evidence is shown now overwhelmingly is that exercise is good, and I'm using very general terms there, but exercise is good, and exercise is really good throughout the continuum. So Shai, for instance, works in an acute care setting. So he's working with patients, the day of surgery, the day after surgery, working with patients with hematologic cancers, getting ready to have their bone marrow transplant. There's a growing prehabilitation is a growing idea within cancer rehabilitation. So working with patients from the point of diagnosis, maybe before they begin chemotherapy, before they have their surgery, to get them more physically ready for whatever procedure they're going to undergo. I worked in the outpatient setting, but even within the outpatient setting, we were seeing patients definitely during active treatment, in between active treatments. So in a lot of cases, somebody had surgery, had chemotherapy, and now we had 2 weeks to get their shoulder range of motion to a point where they can get their radiation therapy. And then it goes way down the line throughout survivorship. You might be working with patients who are 30 years following their treatment, but actually there are late effects of radiation, of the scar tissue that they've had from their surgery that's now creating a physical limitation this far down the road. So it totally spans the gamut, and that's something, not only the timeline, but what types of physical limitations occur from cancer and its treatments. That's something that I didn't know much about before entering the field. But there are some good articles, actually. If you go to the Student and New Professional Subcommittee website, which we can share, maybe somebody can share it through chat. We have a couple must-read articles, and I believe one of the articles on there is does a fair job of describing sort of generally what is seen as sequelae from cancer and cancer treatment.
Thank you.
Yeah, great question.
Great question, Haley. Thanks, Steve. Does anybody else have any questions? We'll give just a couple more seconds to see if anybody wants to ask something.
Steve, I have a question. So seeking a PhD, when you're evaluating programs, is it, but actually it's two parts. When evaluating a program, what are you looking for specifically? And I know it's kind of looking at DPT schools and jobs, you want it to match up with what you're looking for. But also, is it a good idea to have ideas of research topics and seeing if that PhD program is willing to support that and match that? Or do you kind of just want to come in with an open mind?
A little bit of both. So an important part of pursuing a PhD is working with a mentor whose research you're going to be working on, and you're going to be working with that mentor to develop your own line of research. So if you want to be working in oncology rehab and pursuing research in that field, and you're looking at a school that's only doing research about knee osteoarthritis, it might not be a great fit for you. The trick, I think, in our field is that there's not a ton of people out there doing oncology rehab. I got really fortunate, actually. I looked through the faculty list of this program that I was applying to at MGH, and an interesting part of their application process is that they actually require you to find a mentor, find somebody who's willing to be your mentor before you even apply. That's part of the application process. And I didn't find anybody, but I was still interested in the program, like I said, because of the academic piece or the emphasis that they place on that. So I reached out to the program director and said, hey, here's my interest, here's my clinical background, do you have any advice? And he put me in touch with Dr. Lisa Wood, who is now my research mentor. And I admit I had sort of passed over her name because she is a nurse. She's a nursing background. She's also a PhD. But turns out that she is researching cancer-related fatigue and other issues in cancer survivorship. So sometimes it takes an ask, sometimes it takes some digging. But I think that it is important to find a school or a program or somebody, at least in the area geographically, who's working on something that's related to what you're working on. And I say geographic area because MGH, for example, will allow you to have a mentor outside of the school. So I think if you can find somebody in the area, then programs might be open to that. But yeah, like I mentioned, looking at the core curriculum, looking at what classes they encourage you to take or force you to take is important to make sure that it's in line with what your interests are.
Cool. Thank you.
Yeah.
Good question, Andrew. Thanks. So I guess I had a question, before we sort of broke off here for questions. I was thinking about, you were talking about, when you were in clinic, you were thinking about patients not improving in the ways you expected. And, why are we doing A and not B type of thoughts. So what have you thought about recently that has sort of, I know you're doing your PhD, and we'll talk about that topic a little bit later, but has there been anything specific that's been like, that sounds interesting, like I want to pursue that, or that's a question I have that I want to answer? I know your PhD is probably slowly getting honed in, but has there been anything else that interests you so far?
So it's been an interesting process in the context of the pandemic, because I had a great question, which I'll tell you in a moment. And we designed a great study to go along with that question. And we had a doctor on board, and we were about to launch it, and then the pandemic hit, and it all got shut down. And so we've sort of shifted gears and sort of found a different path that I will also tell you about. But the question that I'm really intrigued about, and I think I will still pursue this when able, patients with chemotherapy-induced peripheral neuropathy. Or also, actually, I'll back up. Patients who are off balance, cancer survivors who are off balance following treatment with chemotherapy. There's so much emphasis placed on chemotherapy-induced peripheral neuropathy, rightly so. We know that it impacts balance, and it's associated very, very positively. But the peripheral nerves, somatosensation, is only one of three sensory systems that contribute to balance. So we've got somatosensation, the peripheral nerves down in the feet. But we also have vision, and we also have the vestibular system. The vestibular system, which does travel along a peripheral nerve, although it's a short one and it's very close to the central nervous system. So my line of questioning pre-pandemic was, can we follow a cohort of patients going through treatment with neurotoxic chemotherapy? Can we measure their vestibular function as we go through? Can we measure their visual function and their peripheral nerves? And try and tease out, is it just chemotherapy-induced peripheral neuropathy? Or is there something else at play here? And so that I'm really excited about trying to answer that question. But part of developing that question is also looking at the research to see what has been done out there. And so sort of sneak preview, in January, I'm going to have an article coming out that's a scoping review that looks at all the literature that has looked at the effect of chemotherapy on balance, gait, and falls. And from this scoping review, I've been able to sort of find gaps, and my question does conveniently fall in a gap. But now I'm trying to fill those gaps with my research plan. And I see, before we go too far, I see a question in chat about going for the NCS. Did I go through a residency or did I take another path? I did not go through a residency. And I passed for what that's worth. It's a big undertaking, I think, whether you go through residency or not. I was fortunate enough to be able to link up with a friend who did go through residency, so she had some materials that she was willing to share with me. I think the NCS is pretty well established. There are actually study groups and study guides. Oncology is the most recent specialty to be approved by the American Board of Physical Therapy Specializations, ABPTS. So oncology is still sort of getting its footing. So there's not really well-established study groups or study guides yet, but that's coming. So yeah, that was my path to the NCS.
All right. Well, if no one has any other questions right now, I can hit you with one. And one of them is, do you have any future career goals that you've made for yourself since getting onto your PhD path, or just in general with onc rehab? Do you have anything that besides that question you're trying to answer, anything you want to achieve? Do you have like a 5-year goal or a 10-year goal? And how do you plan to balance that?
Good question. It's all about the balance these days, working from home and doing.
Unintended, Steve?
What'd you say? Unintended. Yeah. Oh, nice. All about the balance these days. That'd be a good article title. So thinking short-ish term, in order to graduate and earn my PhD, I'll have to publish a couple more papers. So to get to earn the PhD, it's sort of a non-traditional route to a dissertation through this program, which I think a lot of programs have adopted. But the scoping review that I just referenced will be my first manuscript of 3. And so I'm in the process of beginning to write and prepare studies that will hopefully develop the second and third manuscript. So that's sort of the short-ish 1 to 2 year plan. Once I earn the PhD, which is certainly a big part of the goal, I hope to get a job at a university in a DPT program. Whether that means staying at MGH, IHP, if anybody's listening, I'm more than open to it. Or looking for another school, maybe Ithaca, if anybody's listening. I'm open to it. So that'll be sort of an interesting process of, preparing to apply and sort of go through that process of job applications, which I feel like I haven't done in a long time. And certainly I've never done from entering into academics standpoint. And then, part of getting a job in academe is developing a research agenda. So that's not just thinking forward to the next paper you have to write to earn your PhD, but it's thinking about like the next 1, 2, 3, 4 studies that you can imagine in succession that are going to help to sort of build a case and answer a bigger goal or answer a bigger question, I guess, or a bigger need in the field. So just using my, vestibular, is that involved in balance impairment idea. The first study might be how I described it, following patients as they progress through treatment. Is the vestibular system affected by chemotherapy? So say that we find that it is. Okay, terrific. A next step to that question, the bigger question and the long-term goal, which is to improve outcomes for the patients, that's sort of my ultimate goal, is maybe to look within hospital systems, are patients being screened for vestibular impairments? And so that might be a study in its own. And then, then maybe the next step is a randomized control trial where we implement a vestibular training system with patients who have been through chemotherapy and see if outcomes are better. And then if outcomes are better, maybe then it's an implementation science study where we go to the doctors and the oncologists and the rehab specialists and say, hey, let's use this protocol that we've laid out and try and actually implement change. So nobody take that, because I think it's a good idea and it's mine. But that's sort of the long-term research goal, I guess, if you're looking for that.
So where does balance all fit in, Steve?
Oh, like life balance?
Yeah.
I love my dog. My dog gives me scratches. No, it can be tough. I think especially, I feel like I'm going to speak to life advice now, but I feel like especially working from home, setting boundaries. It's easy to work around the clock. So setting boundaries and being sure to disconnect on weekends and vacations, even though we're not going anywhere, is important. And there is a lot of joy in it, which I love. So it's like if you're going to the clinic and you're finding a lot of joy in that, it doesn't feel like work. It doesn't feel like it's weighing you down. So that's what I feel like I've been fortunate to find so far, at least in this path. I think I want to call on Barbelia.
Yeah.
Well, Steve, I just wanted to piggyback on your answer about your scholarship agenda, which is so important, and to develop it during these years of your PhD. But I'm wondering if you could look ahead and speak to your ideal teaching load. If you could teach courses, what would you want to teach in a DPT program?
Good question. So the first thing I'll mention is that oftentimes the teaching load or the teaching proportion versus what you're committed to performing in terms of your research varies by the type of institution that you end up at. So if you're at a really research-heavy institution, say like a Duke or a UNC, one of those big research triangle schools, or even at a smaller school, your research load may be 90% of your workload, and you may be responsible for teaching one session of one class a semester or something. While I sort of slant at this point in my own thinking towards wanting to teach, if I had to think of an ideal split, I think I would maybe say like 60% teaching, 30% research, and maybe 10% clinic. I would love to get back into the clinic. That is a sacrifice that I've made currently of not working clinically. Just when I started to miss it, the pandemic hit, and it's like, well, it's tough to think about being in a clinic right now for anybody. So that's sort of the way my balance falls out. And in terms of teaching, I think this is where I would love to pull my passion for neuro back in, and teach, whether it's neuroanatomy. I know it's sort of sick, but I always loved neuroanatomy, neurophysiology, or neurotechniques. I would love to be involved in teaching those. Or I also, from the get-go, I loved gross anatomy. So I would love to be involved in anything in that realm as well.
That's an interesting answer. That percentage split sounds exactly like Ithaca College. Just putting that out there for whatever that's worth.
I hear it's gorgeous up there.
It's gorgeous there.
Yeah. Um, so Steve, just out of curiosity, just so you know, obviously the PhD path it's a long route, and I guess that's subjective. To me, it feels long, but you know, what does that? I guess it's what around 5 years, right, Steve, give or take?
Oh, I hope not.
4 years. I know some
Well,
people do it in
so
5.
the program, this particular program, basically says you got to be out in 5, but they estimate 4 to 5. I am hopefully aiming for even the a shorter end in that spectrum. It is sort of what you make it. I mean, like I said, I'm not in the clinic, so I'm full-time dedicated to this program. So I'm sort of crushing myself with classes this semester. I'm really focused on my research. So I'm hopefully going to be out in less than 4. You heard it here first.
Can you talk a little bit more about like what that path looks like? Like, what does your first year look like? What does your second year look like? Or maybe not year to year, but milestones, you know, if something's within 6 months, or what do those look like?
Yeah, so I can at least speak to my program, and my program outlines 2 years of a core curriculum, and so within that core curriculum, you are learning research design. So you're learning, you know, case study versus cross-sectional design versus prospective, longitudinal, retrospective, randomized control trial, whatever. Statistics, math is also cool. So learning a lot of statistics. And after you've completed your 2 years of coursework, within those 2 years, actually, they also leave room for you to select your own electives. And what's neat about this program and being in Boston is actually we have the opportunity to take those electives at different schools around the city. So I wasn't even going to mention this, but I'm going to Harvard. Not a big deal, not a big deal. So after you finish all your coursework, at least in this program, you sit for your qualifying exam. And the qualifying exam, again, the way this program has structured it is you basically write a grant proposal. You write a grant proposal for one of your studies that you want to do, and then you orally defend it, and they grill you basically on your coursework that has prepared you to carry out your research plan, because they want to make sure that you're not kidding around and faking it, really. This is not a type of program where you can fake it till you make it. You actually have to know your stuff. And so that is actually when you become a PhD candidate. So the posts that went out about this talk sort of put me ahead of the card and called me a PhD candidate. I'm not that yet, but hopefully I'm going to be that come the spring semester when I hopefully sit for my qualifying exam. And then it's sort of up to you as the PhD candidate to do your research, apply for grants, get your own funding. The financial piece, I'll touch on that for a moment. Financial piece is a big consideration for the PhD. And actually, Andrew, this is a good answer to your question as well. When I looked at programs, I prioritized programs that provided a stipend. Not every program does. Some programs will charge you tuition and not provide a stipend. IHP, I was really fortunate. They provide tuition to you. And then my mentor has been generous enough to provide me a stipend through the first 2 years of my program. After that, I sort of get cut off, and it's up to me to provide my own funding through grants. And then I put together my dissertation work and orally defend that, and then I enter the real world for a second time.
Second, third, who's counting at this point?
Who's counting?
Awesome. Yeah, thanks for that input. I mean, it's just interesting to see everything that's involved. You know, I don't know, when I was in PT school, to me, I was like, oh, PhD, like you just apply and then you do research. And there's just so much more involved in that process. Obviously, I've had some friends go to PhDs, and you're in their PhD, so I've heard a bit more. But hearing the process and hearing how things always adapt and change throughout that process is just very, very fascinating.
And there's even, I haven't mentioned it, but there's even a step after getting the PhD where some people opt to do a postdoc. And that is sort of what you described. You sign up, or you sign on with another research mentor that you're responsible for finding somewhere in the country. And you basically join their lab and you do research for a year or two, or whatever the postdoc entails. And it's another opportunity to practice writing, to practice designing and implementing your own study, particularly if you're interested in doing research. That can be an important step in a career path. I'm still on the fence. I don't know if I'm going to go that route for myself.
Yeah, thanks for that, Steve. I'm sure there's a lot more you could tell us about the PhD path, but we will move on for now. So the whole reason we're here is because of the Academy of Oncologic Physical Therapy. I know I got involved, I think probably about 3 years ago because of you. And my role has grown, and it's been awesome to be a part of it. And as you mentioned in the beginning, there's so much growth that you can get from being part of the academy. There's mentorship. There are tons of opportunities, and I sort of want to just get your input, since this is part of the student and new professional subcommittee. How is the APTA oncology growing and developing this, I call it the SNP, but the student and new professional subcommittee. So what are we doing as an academy to help this grow, and where do you see us going in, the next year, 2 years?
So I think in line with the field of oncology rehabilitation, which has really been booming over the past several years, APTA oncology has really developed a momentum within APTA, the mothership. And so there's been a lot of really exciting milestones in the last several years. Like I mentioned, oncology became the 9th and most recent specialty to be approved by ABPTS. And something that we have recognized over the past several years is that there's this wave of students and young professionals, new professionals, who are interested or open to being interested in oncology rehabilitation. And it's really exciting to see. And the creation of this group, the Student New Professional Subcommittee, was an effort to harness that energy and provide opportunities for students and new professionals to be engaged with APTA oncology and APTA beyond that, but also an opportunity for us to identify and develop leaders in the field. As with any field, as with any workplace, there's turnover as people move on and move up in their careers. And so we're sort of looking for that next generation of leaders within the field of oncology rehab to step up and get involved and help push things to the next level. So there's a lot of exciting things happening from a national standpoint in terms of working to get oncology rehabilitation standards implemented through the Commission on Cancer. One of the priorities that the Academy has set is actually to work to get oncology rehabilitation implemented in more curricula around the country in DPT programs and PTA programs. So again, we can sort of foster the knowledge base and leaders from an early stage.
Awesome. Thank you so much for that. It's getting close to the end of our time altogether. So I wanted to check and see if anyone else had additional questions. We can give it another 30 seconds. And then if not, we just have 1 or 2 fun wrap-up questions. So I'll give it a little time. You can feel free to type it in the chat box or just unmute yourself if you have any questions.
Steve, to piggyback off of what you were saying about like the next leaders to step up and everything too, it's not even just at the national level, but at that local level as well. There's a lot of opportunities in certain areas where there's not the skilled clinician in oncology rehab or even in exercise oncology, and these doctors and these radiation oncologists and everybody are starting to look at that and realize that they don't trust just any old physical, I don't mean he's old either, but any physical therapist, because there's, I've talked to physicians and they've been burned once or twice and they're like, no, I don't trust anybody. And, like you gotta, like, they basically vet you almost. So having that background knowledge and being able to speak their language and at the local level and within the local systems is huge too, because that's where the patients get missed.
That's
It's Sloan. It's internationally known. They know they have that great physiatry team that screens and refers, but at local hospital systems, it's not always in place. And having that knowledge and being able to, connect with other professionals too, that helps, because then you can say, hey, this is what I've experienced. These are the other people I know and I talk to, and this is how it is. And you can try and implement that way. That is huge. And a lot of patients are getting missed. And that's what, going through my residency seeing it at a local level. It's a lot of patients get missed. And for me, I don't want that. I want everybody to get seen that needs to get seen. So there is a lot of opportunity to, if you can't get involved in the national level just yet, to step up in your local level and try and find out ways to get involved and ways to educate as well too.
Thank you, Andrew. And I'll put Andrew on blast a little bit. Andrew just graduated from an oncologic physical therapy residency at Beaumont Healthcare in Michigan. So take his name down if you're interested. Hit him up. I'm sure he's interested. But Andrew brings up a great point. And maybe this is a good way to say it. The number of cancer survivors in the United States is booming. There's like 17 million cancer survivors in the United States today. So no matter what setting you're going to be working in, whether it's outpatient or inpatient or sports or subacute nursing facility or acute rehab, you're going to see patients with a history of cancer. So I think that's a big message that APTA Oncology is trying to get out as well, is even if you're not going to be a cancer rehab specialist or working in an oncology rehab setting specifically, we want physical therapists to have the skills and the knowledge. Skills are pretty much the skills that you have in any of those settings anyway, but the knowledge and the understanding to be able to treat those patients safely and effectively.
And I'll add one more thing, because I've had a couple students, one recently, but I've had probably close to 5 or 6 students in the past ask me, like, where do I find a clinical internship? And I know they're tough, but at the end of the day, Steve, like Steve said, everywhere you go, you will encounter someone who has the diagnosis of cancer of some sort. So if you don't end up in a place that is a cancer specialty, which may happen, just do a thorough chart review. I'm sure you'll find some cardiotoxicities, some pulmonary effects, some peripheral neuropathies. I mean, you'll find neurological effects, range of motion deficits that they're not being treated for. So I think that's if there's, for me, one thing I always try to find these cancer rehab hospitals, but in reality it was right in front of me pretty much the whole time, and I didn't really have to go searching for something specific. And I might have even learned more from being in a place that was maybe an outpatient orthopedics, clinic, that I just looked more in depth at these patients that had these cancer diagnoses. So I urge people to not, look for your cancer internships, but also be aware that wherever you go, you will have people who you're treating who have these diagnoses and have these side effects. And I think that's important to realize, especially like Andrew said, in these communities, that at the community level, it's so important.
Yeah, 100%. It was like, I did my case study for school with a cancer survivor on my second clinical in a private facility in Burlington, Vermont. It wasn't a cancer-specific center. She just happened to have, been referred to physical therapy at the center. And they were very inclusive, and they asked me what my interests were, and I said oncology. So when she flagged she had a previous history of cancer on her intake form, they're like, okay, you can go with that, her and her student today. And then I ended up working with her and doing my case study on her. So it's by sheer luck, but just speaking up and saying, hey, these are my interests. Is there any way that, do you guys see cancer survivors? Is there any way I can go and shadow with a surgeon that's at a local hospital or anything, just to get in and learn that way? And two, if you end up in a place that is, isn't a cancer center or doesn't have a strong cancer system, even asking if you're willing to step up and take the lead and try and help develop something and figure out where the tumor boards are at in the multidisciplinary clinics, and really stepping into that role as that clinical specialist in oncology. You know, like I did my residency with Beaumont and I'm staying with Beaumont. I'm just transferring hospitals, but still, like for me, transferring hospitals, I need to reintegrate into tumor boards and figure out where our deficiencies are in that hospital now with their tumor boards and their multidisciplinary clinics. So basically that's what my goal is to figure out where our deficiencies are and how can we make this hospital match other hospitals in the area for our cancer care so that these patients are getting, you know, the same quality care. So there's always room to kind of wiggle your way in into those areas that you like. And even if it's not oncology, if it's neuro, if it's orthopedics, it's just speaking up and trying to find the avenue of least resistance to get your foot in the door. And then once your foot's in the door, you can take off.
Well, that was actually a really good discussion. I think it's very valuable what you all contributed to that, especially by saying how you can take different avenues to get the most out of your clinical experience as a student, even if it's not necessarily the setting you thought you'd find yourself in or the population you thought you'd find yourself treating. So I just want to kind of wrap everything up since we're getting close to that 8:30 mark, and I don't want to keep anyone past their bedtimes. But Steve, we have a couple of funny questions to ask you. I guess maybe not funny, but a little more lighthearted. The first one is, what is your favorite muscle in the body and why?
I've always had something for sartorius. But I've also always had something for the serratus anterior. I think I like its digitations, and I think it's an unsung hero.
2 S muscles, okay.
Maybe that's fine.
Maybe it's just the S. S is your letter of your first name, you know.
Mm-hmm.
The last one is, do you have a funny mnemonic that you either remember from PT school or that maybe you have just for everyday use to help you remember something?
I only remember one mnemonic from PT school, and it's for the carpal bones. And I'll never forget the carpal bones because of it. Some lovers try positions that they can't handle.
Of course.
And that's the only one I remember. I know there were others, but that's the one that has stuck with me.
Well, at least it did its job and it stuck with you.
Right.
If anyone else has any questions, we've hit the 8:30 mark, but if anyone has any last minute questions, or anything they'd like to add, please feel free to do so. If not, thank you all for attending and coming to hear Dr. Wechsler talk. I hopefully got your name right that time. But we really enjoyed all the information you've given us and all the questions you've answered for us. I at least can say that I've gained a lot from this career chat. I'm sure the rest of us have as well. So thank you so much.
It's been great. Thank you guys for having me. If you found this via social media, I think I'm tagged, so feel free to reach out if you'd like. Or Barb, you can feel free to share my email with any of the bombers on the call.
Thanks, Steve. I will.
We will be sharing this hopefully on some platform. We are still figuring out, but it will be shared on some platform. We'll let everybody know. We do have another one coming up. This is going to be continuous. It should be, hopefully, I know it's a little ways down the line, but maybe early January, mid-January. We're still figuring out the date, but everyone will be kept in touch. We will be talking about residencies. So just as a sneak peek, if anyone's interested or has any thoughts or questions, obviously that's something that's been growing. More residencies have been, oncology residencies have been up around the country, being created. So, and I know more people are interested. So just as a heads up, that's going to be probably our next one. Any feedback is also welcome since this is our first chat. And yeah, thank you for joining us. Please feel free, if you have any questions, you can still ask them, but we are going to wrap up. So we'll hang out for, Steve, Michaela, and I will hang out for another minute or two, but if we are done as of now.